Hello, good morning, everyone. Welcome to Grand Rounds. It's my pleasure to introduce Dr. Claudius Mahr. I was told that I could just say his name and that he works here and then start, but I won't let that happen. After completing his undergraduate degree in Munich, Dr. Mahr completed his medical training at Midwestern University and residency in internal medicine at Northwestern University. At the University of Illinois, he completed fellowships in cardiovascular medicine and echocardiography, as well as a fellowship in advanced heart failure and transplant cardiology at Northwestern. So after holding positions at the Medical College of Wisconsin as medical director and section chief of advanced heart failure and transplant cardiology, as well as program director for the Advanced Heart Failure and Transplant Fellowship, he came to the University of Washington in 2014. And here he's a clinical associate professor of medicine and cardiac surgery, director of clinical integration at the Regional Heart Center, and medical director of the Mechanical Circulatory Support Program at UW. So he specializes in comprehensive longitudinal care of patients with heart failure and cardiomyopathies, utilizing the latest in medical, surgical, and device therapies, including assist devices and cardiac transplantation. He has authored the Cecil Essentials of Medicine book chapter on heart failure and has studied the factors affecting outcomes in mechanical support devices. He has multiple ongoing LVAD trials. He's an active member of the American College of Cardiology, the European Society of Cardiology, and the Heart Failure Association of the ESC. He serves as a council member of the International Society of Heart and Lung Transplantation and has editorial responsibilities for leading journals in cardiovascular medicine and transplant. So please join me in welcoming Dr. Claudius Mahr to speak on the heart failure continuum, an overview of contemporary practice.
Thank you for that very, very kind introduction. I guess that's emblematic of maybe my need to say no to more administrative obligations. Here are my disclosures. What I thought we would do is take a little time to talk about the continuum of heart failure, because there are some clear evidence gaps in my field that don't necessarily make it into the guidelines in a pragmatic way yet. So we'll talk a little bit about some background information. And acute heart failure, which is probably almost an orphan disease compared to other cardiovascular diseases. We'll spend the bulk of our time talking about chronic heart failure and what's new in medical therapy. So most of you are aware that heart failure is exceedingly common. 8 million Americans, 500,000 newly diagnosed patients every year. It's the single biggest ticket item for Medicare, and it has been for a very long period of time. But I think what not everybody appreciates is the fact that the number of deaths from heart failure in the US exceeds the number of deaths from malignancies. And what's so interesting about this statistic to me is I think it's related to our messaging. There was a very kind of thought-provoking European study that asked patients with heart failure what they thought their life-limiting illness was. And lo and behold, 90% of them said it was going to be cancer, even though heart disease and heart failure is worse than cancer. You can look at other entities and orphan diseases, and I don't know if anybody is aware of who these two are. So here's my pop culture reference, Ellen DeGeneres and Kim Kardashian. So this little stunt raised more money for ALS research than the initial BI spends for acute heart failure every year. So quite stunning considering the prevalence of this disease. When we approach heart failure, we really don't treat it as much as a diagnosis as a clinical syndrome. So it's if you will, an umbrella term for a number of different symptoms that results in a composition of a clinical picture in which there's a structural or functional failure of the heart to either provide blood flow or to fill with blood. And I think the most important part to this is that heart failure is not necessarily congestive, because many of you, and the way I was trained, we thought of heart failure largely as an entity of the elderly, volume overload type of phenomenon. But for many of our patients, their main manifestation of of heart failure is not volume overload, but it's impaired cardiac output. So you can have heart failure without any stigmata of volume overload. And obviously, there's a tremendous amount of heterogeneity. You can see in the middle a normal cardiac phenotype, both on imaging and on pathology. On top, you can see systolic heart failure or heart failure with reduced systolic function. And on the bottom, you see this entity, sometimes called diastolic heart failure or heart failure with preserved EF, which is a hodgepodge of disease entities, hypertensive, diabetic, ischemic, where the heart is stiff and unable to relax. And that's about half of heart failure in the community studies. The reason this is a problem is, as of 2016, there's not a single beneficial evidence-based therapy for this. What happens in a normal heart is there's a fairly defined pressure-volume relationship. In systolic heart failure, you can see that curve shifts to the right. And this is the reason why patients with severely reduced systolic function, EFs of 15%, can still live, because for any given ejection fraction, there's a change in their stroke volume. Notice the curve on the left side. It's very, very steep, and a small change in volume will result in a large change in pressure. And this is essentially the pathophysiology of heart failure with preserved EF. Since there's no effective therapy other than treating blood pressure, diabetes, dyslipidemia, coronary disease, I'm going to leave it at that and focus the rest of our discussion on heart failure with systolic dysfunction. When you look at the pyramid of heart failure, you can see that when you go from stage A to stage D, the pyramid becomes very much smaller. And I spend my clinical time with the stage D patients, so patients that are medical therapy refractory. And really, when you get to that point, there's very little interventions available, and we will talk about those in a little bit of detail. So the first clinical entity that I want to spend a little bit of time on is the concept of acute heart failure or cardiogenic shock. And for any of you that remember what happened in sepsis and in cardiovascular care for acute coronary syndromes, there's been this evolution to a system-based strategy of care where you identify high-risk patients, make a timely diagnosis, and then intervene in a very proactive and deliberate way. Unfortunately, we have not accomplished that in the setting of acute heart failure. So when we think about acute heart failure, it doesn't matter what the underlying cardiac phenotype is, whether it's systolic or diastolic. There is a decrease in cardiac output and a decrease in stroke volume, and an increase in pressures inside the heart. And this can happen to any heart. It happens with fulminant myocarditis in patients who were previously healthy. It can happen with patients with chronic ischemic disease who have an acute coronary syndrome. But eventually what happens is the pressures inside the cardiac chambers exceed the pressure down the coronary arteries. When you get to that point, the heart essentially goes kaput, and multisystem organ failure ensues, and ultimately death. So in trauma care, there's the concept of the golden hour. In acute coronary syndromes, there's the immediate cath lab activation. And for those of us who spend our time working on guidelines and things like that for heart failure, this is probably the critical issue that we're dealing with right now, is to try and get health systems to move in a way where within an hour of the patient presentation, there is an attempt made to stratify the patient and provide a more definitive type of therapy. So one easy way to stratify patients is just with a simple pulmonary artery catheter measuring cardiac index. And you can see that below a cardiac index of 2, the risk of dying from pump failure increases exponentially. And this has been replicated over and over, and this is also the reason why all contemporary advanced heart failure trials have used a cardiac index of 2 or less as an enrollment criteria for ventricular assist devices in cardiac transplantation. So at that point, historically, what happens is we try things like inotropic support, dobutamine, milrinone, things like that to try and temporize patients. But the problem is that strategy has very limited success. This is data from one of the ventricular assist device trials, and this is the arm of patients who are neurohormonal therapy intolerant, requiring any kind of inotropic support. And so there's this concept of somebody, quote unquote, being stable on inotropes. And when I hear this, particularly at 3 o'clock in the morning, I'd be hard pressed to stratify a patient who has 90% 1-year mortality as stable. So I think this is a misnomer and really the clinical inflection point of the moment of free fall. So when we think about mechanical circulatory support with our current device technology, what we have to recognize is that we're talking about a subset of patients who has an inordinate high risk of mortality, but a limited window of opportunity to have a successful outcome. So our current indications are an impaired cardiac index, limited contractile reserve, any kind of electrical instability. And surprisingly, it doesn't matter if it's AFib or VT or something in between. When the heart becomes electrically unstable, that portends a poor prognosis. And this is the smorgasbord of devices that we currently have available for short-term support, ranging from the intra-aortic balloon pump on the left all the way to extracorporeal membrane oxygenation. We could talk about this in and by itself for an hour, and I don't want to bore you to death, but I think suffice it to say that there are unique nuances to each support strategy. And historically, many institutions have focused on the intra-aortic balloon pump as the default option. As you can see here, the amount of incremental support from the balloon pump that you get is only about 0.5 to 1 liter per minute. And the other, I think, really important consideration about the intra-aortic balloon pump is the fact that when balloon pumps cease to work for any given patient, they don't do so in a predictable and progressive way, but they do so in a sudden and catastrophic way. So there are many patients for whom a balloon pump in acute heart failure is perhaps adequate. But when you fail the balloon pump, you fail spectacularly, not predictably, because at some point, the pressure down the coronary arteries, again, is insufficient to maintain cardiac blood flow, and the patient will die. This is the reason why in the most recent iteration of the European guidelines, the balloon pump has gotten a class 3 recommendation. Do not do this routinely for cardiogenic shock. What has emerged recently is a percutaneous strategy with a device called Impella. It's a cath lab inserted device. All of our interventional cardiology colleagues are incredibly facile at using this device here. But in order for this to be successful, it has to be proactive. And if there's any take-home point about my field of mechanical circulatory support, is that the data has uniformly shown that patients who undergo support with a device earlier and proactively do better than patients who do it later. And this is irrespective of age. You can see that for patients who are age of 70, in this case, get an Impella device, their outcomes are inordinately poor, but irrespective of age, with earlier type of support, the outcomes are better. And again, I think what's encouraging is that there are patients who benefit from this technology, and we just need to better define in which direction we're going in this regard. So when it comes to chronic heart failure, the picture is quite interesting because this is a large population study not done on any coast. It's a small Midwestern county, Olmsted County, Minnesota, and for those of you who are not familiar with it, that's where Mayo Clinic has its health system. So this is a largely white, very insured, homogeneous patient population with access to Mayo Clinic. And in their hands, 60% of patients die from heart failure within 5 years, so worse than most malignancies. When you look at these neat Kaplan-Meier curves, though, what's lost is the fact that the heart failure trajectory is different from cancer. It's not a progressive linear type of trajectory, but it's one where there's this period of dips and plateaus of decompensations and recompensations, and that makes it difficult to even engage in patient conversations, right? Because the very nature of the disease trajectory means that you're going to have a limited of time to approach patients and their families about their therapeutic options. And the ideal timing of this has never been defined. None of us make decisions, good decisions, in times of crisis, and yet that's what we're asking our patients and families to do. So I'm going to take the next part of my talk to talk a little bit about how we can better stratify patients along this clinical course, realizing that it's dynamic and imperfect, and hope to give you some tools that you can use to educate your colleagues in the community that refer to you to stratify their patients in a more granular fashion. So I think it's clear that a heart failure hospitalization is a sentinel event in a patient's disease trajectory, because within 30 days of that hospitalization, 1 out of 10 patients are dead, 1 out of 4 are readmitted. And if you look beyond the 30-day administrative arbitrary line in the sand, readmission rates at 6 months approach 50%. And I'm going to tackle a little bit of political plutonium, because I think in the interest of systems-based care, there's some important considerations, and that's, all of us are getting dashboards and data about our 30-day readmission rate and what we can do about mitigating that. And I think it's clear that heart failure patients are likely to come back with heart failure, but as it turns out, the most common reason for readmission for acute coronary syndrome patients is heart failure. And the second most common reason for pneumonia patients to come back to the hospital is heart failure. It's either because sometimes the diagnosis is a little bit soft and uncertain, or perhaps what's good for pneumonia, IV fluids and antibiotics, is not so beneficial in somebody with a heart failure phenotype and limited contractile reserve. The other part that hasn't gotten much press is the concept of readmission versus mortality. And as it turns out, they're competing endpoints. If you look at Medicare data, the hospitals that had higher readmission rates had lower mortality and vice versa. So some of us have quipped in a callous way that any intervention that will increase mortality will also reduce our readmission rate, but probably not the solution that we should take as a health system. The other thing that's really important is the concept of early follow-up. And this is particularly challenging in a large health system because many of us have academic and administrative responsibilities and limited ability to accommodate patients in our clinic. And it turns out that, yes, even though 25% of patients get readmitted within 30 days of discharge, 60% of these readmissions actually happen in the first 2 weeks. So I want to give credit here to our transitions of care team and the excellent work they've done on dealing with this vexing problem. So going back to the stratification piece, if all we know about our patients is the number of acute care episodes, we can actually stratify them quite granularly. So after the first hospitalization, you can see mortality is about 40% at 2 years. But if you look at median survival, it turns out that between the second and third hospitalization, we're talking about 6 to 8 months of expected life. And I think that makes a very cogent argument for proactive goals of care discussion, and I think emphasizes the importance of providing patients who are candidates for more advanced heart failure therapies an early answer. This is something that I think is lost a little bit because it's always intriguing to me to walk into our team rooms and sort of see patients almost become avatars of virtual medicine. And I think there's still a lot to be learned by actually talking to patients and their families. So just the question of How many pillows do you sleep on? Do you wake up in the middle of the night short of breath, have to sit on the edge of the bed? Gives you a 20% mortality difference in terms of stratifying somebody. So patients who are unable to achieve freedom from congestion have much worse outcomes than patients who do not. There are other tools that we can use, and many times with our colleagues from our pharmacy team, to very easily stratify patients, and part of that includes the intolerance of neurohormonal therapy. So if you look at beta blockers, which are incredibly poor blood pressure medications, the average blood pressure reduction from a full dose beta blocker in a healthy heart is probably about 7 millimeters of mercury. You can see here that on the x-axis, we have 90-day timeline, and on the y-axis, 25% mortality. Patients who have to have their beta blocker withdrawn have inordinately poor outcomes. And again, this has nothing to do with the beta blocker itself, but it has to do with a heart failure phenotype with limited contractile reserve, where even a low dose of a beta blocker can't be tolerated. It's even more compelling with ACE inhibitors and angiotensin receptor blockers. This is something that we have not seen an exception to. Patients that are ACE inhibitor tolerant with more advanced heart failure do much better than patients who have a creatinine limitation to an ACE. But if you have somebody who gets a homeopathic dose of lisinopril and the next day their creatinine is up and they need dobutamine or dopamine or anything the like, that Kaplan-Meier curve is straight into the x-axis. So I would submit to you that every heart failure acute care episode should be considered a warning sign and a bridge to something for all patients to make a concerted effort to optimize their medical therapy. For patients that are candidates for it, CRT, BiV pacers, revascularization, and then for the about 10% of patients in our system that fail that, more advanced heart failure therapy. When we look at neurohormonal therapy, there's a plethora of choices. And being a European reductionist, I'm going to try to make this somewhat simple. And I think it needs to be made simple in order to become more reliable. When we look at neurohormonal therapy in clinical trials, the doses are not determined by therapeutic response, but they're automatically escalated. And tolerance limited up-titration is done mostly by pharmacists, not by physicians. And in that fashion, you can get 66 to 80% of patients onto target medical therapy. In the real world, it's much more disappointing. Black is dose reductions, white is no change in dose. So you can see that 80% of patients fail to have their beta blocker dose increased or titrated, leaving us with less than 20% of patients actually on a target dose of a beta blocker after their heart failure diagnosis. The other staple of heart failure therapy is ACE inhibitors, and they also have been shown to improve survival. They're immediately beneficial before they do anything to renin, angiotensin, aldosterone. They just reduce afterload. So they make it easier for a failing ventricle to pump blood in the right direction. And they should be up-titrated every 2 weeks to target dosages depending on the medication that you choose. And again, they are immediately beneficial. Contrast that with beta blockers, where the benefit is not immediately beneficial. This creates a patient messaging problem. And I think it would be really beneficial for us as a field to have the conversation with patients and their families to say, yes, your carvedilol or metoprolol is life-saving and will reduce your mortality and will make you feel better, but you're going to feel tired and fatigued and a little bit out of it as soon as you start taking it, and the benefit is not going to kick in for at least a couple of weeks. So I think it's an important messaging opportunity that will help adherence and getting patients to where they should be. So the next question is always, what should the third drug be? And I think I'm going to, again, try to make this fairly simple and say for patients that are on an ACE inhibitor and a beta blocker at target dosages, if they have normal renal function, normal potassium, and you know that you have a reasonable chance of seeing them in clinic again, aldosterone antagonists are great. They're antifibrotic. They have shown incremental benefit in this setting, but they do require close follow-up. For patients who either have abnormal renal function or potassium, or follow-up is less certain, hydralazine and isosorbide has been shown, particularly in African Americans, to be incrementally beneficial, and it's a strategy we use, again, in the setting of renal dysfunction, hyperkalemia, or somebody who is perhaps prone to less than stellar follow-up. There's been a really exciting development in our field in the last couple of years with a new drug, and the new drug is a combination of a angiotensin neprilysin inhibitor. So it's an ARB coupled with sacubitril, which is a neprilysin inhibitor. And this has been the first new medication that has actually shown a robust improvement in outcomes, and conceptually makes a lot of sense. So you take an angiotensin receptor blocker, which we know is helpful, and what the industry has done here is added neprilysin, sacubitril inhibition, and what that theoretically does is favorably impacts the natriuretic peptide cascade. So for those of you that remember the natriuretic peptide types of therapies, this is a pill form of that, and this has actually great promise in the sense that with a number needed to treat of about 20, we can see a significant reduction in most of the endpoints that we care about, which is heart failure, death, rehospitalization, and overall mortality, which was surprising. So this is incredibly encouraging, and more clinical trials are needed to study this in other settings because the current data we have was limited to stable outpatients. They all had to be ACE inhibitor tolerant, so they required 20 milligrams of enalapril or the equivalent thereof for 2 weeks with a systolic blood pressure of above 100, and 90% of patients were functional class 2 and 3. Less than 1% of patients were functional class 4. There's a different clinical trial sponsored by NHLBI called LIFE, which is attempting to look at this in a sicker patient cohort. And we hoped to be part of this study and get that off the ground here because I think it's going to be an important contribution to this field. So the data for more advanced heart failure doesn't exactly exist yet. I think the other underappreciated fact that brings us back to the concept of getting patients euvolemic decongested is really just how much diuresis do you need? I think for many non-heart failure clinicians, any rise in creatinine on diuretic therapy is somewhat disconcerting. For us, this is actually a good thing because there are data that support that if you can get patients diuresed to the point of hemoconcentration where you have a modest rise in creatinine, an increase in hematocrit as a surrogate for contracting intravascular volume, those patients, as you can see, do better than patients who leave the hospital with residual hypervolemia. So I borrowed a slide from Dr. O'Brien, who gave a talk about this as a summary for our Northwest Heart Failure Collaborative, because I really like his concise and systematic representation of this. And that's to say, when you see somebody with decompensated heart failure, the first step is to get them decongested, then to use vasodilators, ARBs, ACE inhibitors for patients that can tolerate them. Defer the beta blocker until patients are close to euvolemic and have some vasodilator on board. And I think this is supported by the aggregate of the beta blocker evidence, because all beta blocker trials in history have shown no mortality benefit for the first 60 days. So there's no urgency to start those medications. The mortality benefits happen after that period of time. And then add a aldosterone antagonist if patients are not suffering from hyperkalemia, poor renal function, or poor follow-up. I think it's also important to mention that the benefit of digoxin has become less and less certain over the last 10 years. And the data that we do have that showed perhaps a reduction in rehospitalization precluded the beta blocker era. So we don't have any clinical trial data on digoxin with contemporary neurohormonal therapy. And in fact, there's a lot of registry and observational data that in fact it may increase mortality. So take that for what it's worth. And then to get patients euvolemic as defined by their baseline weight, and at that point try to get a blood pressure of about 90 and a heart rate of greater than 60. So most patients will tolerate this, and the 5 to 10% that do not, we characterize as having more advanced heart failure. The way we define advanced heart failure is a little bit in the eye of the beholder, and again, I'm going to evoke the European reductionist approach to say that the probably most straightforward definition is patients that are NYHA class 3B or 4 and have either episodes of fluid retention or reduced cardiac output at rest. And for many of our elderly ischemic cardiomyopathy patients, that's very straightforward. For young women with myocarditis or peripartum cardiomyopathy or chemotherapy-mediated cardiomyopathies, that's a little bit more difficult because they're devoid of any stigmata of volume overload, however have severe systolic dysfunction and severely impaired cardiac index. Echo is helpful because if you see marked systolic dysfunction, that's a clue that patients are going to be more high risk. Cardiopulmonary exercise testing is also quite helpful and in fact necessary when we talk about more advanced heart failure therapy like ventricular assist devices, cardiac transplantation. But I think the most straightforward way to stratify patients is to simply ask, are you able to walk a block or a flight of stairs? So if you've tried good goal-directed medical therapy and all the other tools we have, IV pacing, revascularization, all of those types of things, if patients cannot accomplish that goal, then by this definition, they would be characterized as having more advanced heart failure. The options we have available for advanced heart failure therapy have expanded in the last few years. This is an overview of the current ventricular assist devices that are either on the market or investigational. The one that started the contemporary era is this one down here, the HeartMate 2. It gained some notoriety when Dick Cheney, the former vice president, received one as a bridge to ultimately a heart transplant. And unlike the historic volume displacement devices, these are much smaller and miniaturized and able to be used in a larger number of patients. As life-saving as this has been in Europe, this has become a legacy device with the approval of the smaller centrifugal types of devices. Because the mechanical reliability of the HeartMate 2 is not as good as the subsequent generation of devices. So on top here, we have the hardware HVAD, which sits directly on top of the heart in an epicardial configuration and pumps blood from the failing left ventricle into the ascending aorta. Patients wear this VAT belt or European man purse or whatever you want to call it as a power source. And during the day, patients are connected to batteries, and at night to a power source with a very long cable. There are some immediate limitations to this that come to mind, and if you think about this from a patient standpoint, you're talking about a percutaneous device that's attached to a power source, and you're talking about a percutaneous lead that exits the body that's essentially a superhighway for bacteria to make it into the system. Keeping those limitations in mind, this has really revolutionized the care of end-stage heart failure patients. And you can see just by the size of the devices that we're able to use these in smaller patients, women. There's been expansion into pediatric use with this. This is the new kid on the block, the HeartMate 3, now made by St. Jude, formerly known as Thoratec. And we are participating in all of these clinical trials to try and elucidate what the best strategy for medical therapy refractory patients should be in 2016. Recall my slide about 90% mortality at 1 year on an inotrope. And I think this frames nicely what our current VAD outcomes look like. This is the most recent bridge to transplant cohort. You can see that at 2 years, 82% of patients were alive. And over time, the number of supported patients in green decreases as the number of transplanted patients increase. However, the curves don't intersect for over 2 years. So nationwide, if you have end-stage heart failure and you're a transplant candidate, you can expect to wait as long as 2.5 years until a suitable donor becomes available. Though everybody talks about it, less than 8% of patients recover native heart function during device support and are able to have their device explanted. And, you know, that's probably still the ideal option, but if you drill into this cohort of patients, the ones that do recover, they're younger, have less fibrosis on their biopsy specimens, shorter duration of heart failure, and we try to treat everybody as though they have the potential to recover, but of the 3 to 5% that do recover, 25% die after their VAD is explanted, 50% get heart failure yet again, and another 25% enjoy a sustained remission from their heart failure. So not exactly overall encouraging. So I'm going to leave you with a few clinical pearls that I think are becoming truisms in the management of heart failure. When we talk to patients about sodium restriction in the United States, it's a very challenging concept, even on the health-savvy West Coast. The picture on the right here is a patient of mine at Northwestern, and she would come in every 2 weeks like clockwork with heart failure exacerbations, and you can see that there's a Morton salt on her nightstand. And when we asked her about that particular issue, she said, well, every time I come in, you have me on a no sodium diet. And so I decided to bring my own to make this work. The patient in the middle here was from another one of my previous institutions, and this particular gentleman had to have his aldosterone antagonist discontinued because of hyperkalemia. And it turns out in this case it wasn't the patient, it was our cafeteria who supplied him with an ample amount of Mrs. Stash as a salt substitute. And for those of you that are not familiar with Mrs. Stash, it's a potassium-containing compound. So In addition to our electrolyte repletion and Mrs. Stash, he became very, very hyperkalemic. And ultimately, we dealt with that both at the cafeteria and the pharmacy level, and were able to get him on aldosterone antagonists. It's important to defer the beta blocker, as I showed you from Dr. O'Brien's slide, when patients are hypervolemic, because cardiac output is heart rate times stroke volume. So if you take away somebody's heart rate and they're dependent on their heart rate for their cardiac output, you may precipitate a decompensation. So it's important to get patients euvolemic first. And then I think it's also important to keep in mind that the titration has to happen deliberately and really on autopilot. So I think the best thing we can do for our patients is to say, let's empower our nurses with a collaborative practice agreement that's supervised by our pharmacy colleagues to say, every 2 weeks, a patient should have their ACE inhibitor and beta blocker increased in alternating fashion, one or the other, until they're at target dose. It's also important to spread out the dosages. Many patients who are deemed neurohormonal therapy intolerant actually aren't. If you spread out the medication dosages a little bit. This is a patient of mine, also from one of my previous institutions, who came to the ER dizzy and bradycardic. And because of the medication reconciliation mechanism, she had one beta blocker from cardiology and another beta blocker from her primary care physician. So double beta blockers and a bucket of pills is not a recipe for success for frail geriatric patients. And this also requires a thoughtful medication review at each visit. Because many patients will get medications that interfere with their neurohormonal therapy. One example that comes to mind is the elderly male with a large prostate. So you have somebody who's stable on a beta blocker, they're doing okay, they're on 25 or 50 milligrams of carvedilol twice a day, and all of a sudden they come in with syncope. Not infrequently, they are started on an alpha blocker, something like Flomax, for their prostate, which of course then results in pretty marked hypotension and sudden syncope type of attack. So it's important to engage our pharmacy colleagues, do these medication reviews, especially for elderly patients. I think it's also important for the general internal medicine community to be mindful of these poor prognostic signs that I reviewed, and to really consider a referral for advanced heart failure therapy earlier rather than later. Because again, the data on this is uniformly positive, that patients who make it to that point when they're less sick do much better than patients who get to this point when they're more ill and have end organ dysfunction or malnutrition. There are some great resources available that you can share with your colleagues, including the newly updated European heart failure guidelines. There's a great scientific statement from the American Heart Association about medications that may cause or exacerbate heart failure. There are many, and I think the best thing to do is just to engage our pharmacy colleagues in that conversation and put that on our radar. We have another wonderful resource that not all of you may be aware of, and that's our Northwest Heart Failure Collaborative, which is a part of Project ECHO and the telehealth system support. And this is a HRSA grant that allows us to provide heart failure education for the WAMI region. And we have a bi-weekly teleconference with case presentations and didactics and things like that. So I would encourage you to consider that. And then I think in light of recent developments, I'm going to close with this slide from a statistic from The Onion, which it turns out that no matter what we've done in contemporary medicine, overall world mortality rate remains at 100%. So I will take any questions or comments.
We have time for a few minutes of questions.
I've left you speechless and...
Yeah, Claudius, very nice overview. A little bit outside the area that you talked on, but in heart failure with preserved EF, there's this controversy about spironolactone and whether it was the poor treatment of the Russian arm that prevented a positive finding in that study. What is your approach to using that drug in heart failure with preserved EF? And maybe you could review that controversy for everybody.
Yeah, what Dr. Diuresis brings up is the concept that I try to conveniently gloss over. And that's the reality that we don't have evidence-based therapy for heart failure with preserved EF. What we know is we have stiff ventricles with a distorted pressure-volume relationship. So a small change in pressure results in a large change in volume. The problem that Dr. Diuresis is alluding to is the clinical heterogeneity in the patient populations. So there are some patients with hypertensive heart disease where all you have to do is control their blood pressure and their heart failure with preserved EF improves. There are some patients with diabetic cardiomyopathies where on histology you can see these very lipid-laden, fatty, grisly, Wagyu beef-looking ventricles that don't exactly contract and relax the way they're supposed to. And Dr. O'Brien and his lab has done a tremendous amount of work on this. And the problem is when you lump all of these together into a HFPEF trial, then you're hard-pressed to figure out who benefits from what. So ACE inhibitors, angiotensin receptor blockers, aldosterone antagonists, all of these things have been tried in HFPEF. And while there are some encouraging signals in different subgroups, we don't know overall what we should do with these patients. So to me, the reductionist approach is treat hypertensive heart disease according to guidelines, treat diabetes, dyslipidemia according to guidelines, reconcile that narrow euvolemic window in a trial and error fashion, and sometimes it's helpful to get a right heart cath on patients to define a euvolemic type of state for them. And I think that's all we can do. There is a HFPEF trial with neprilysin inhibition that's enrolling. But I think at this point there's no panacea and not even treatment that can be recommended. I think aldosterone antagonists make a lot of sense because of their pleiotropic effects. It's worth trying those in terms of their antifibrotic characteristics. But in terms of outcomes data, unfortunately, we're not there yet. And the nihilist in me doesn't think we're going to get there because we keep mixing different phenotypes and different etiologies into the same clinical trials. We were one of the highest enrolling top CAT centers when I was at Northwestern, and seeing those patients, it was really a motley crew of heterogeneous pathology.
You recommend deferring a beta blocker until the patient approaches euvolemia or initiating one. What about the patient who's admitted on a stable dosage and is warm and wet, not in shock? What do you recommend us doing there?
That's a great question. And the patient that you're describing should have their beta blocker continued. The only time that you would decrease or discontinue the beta blocker is if you have clinical reason to suspect that they're deteriorating into cardiogenic shock, so systolic blood pressure less than 90, tachycardic, that kind of thing. But the preferred strategy is continue the beta blocker for patients that are tolerant. I think the most important concept, and I'm going to beat a dead horse, that we've been remiss in our messaging, is to tell patients that they're going to feel worse before they feel better. Because that explains why less than 30% of patients actually take their beta blocker as prescribed. And that's perhaps a messaging opportunity for us.
Okay, thank you so much for coming to speak.